Hello again. So now we'll move on to Module 4, and this module is all about skin problems in the breast. First, patients can have itching, they can have discoloration, and they can have ulcers or cavitation in the skin. And lastly, patients can present with thickening, or the more concerning kind of thickening, the peau d'orange or skin of an orange. So first we'll talk about itching, and itching comes together with rashes. If we see itching or rashing of the nipple, we worry about Paget's disease of the nipple. And this presents as an excoriated appearance of the nipple. It looks eczematoid. It's reddened, a little bit raw looking on the surface of the nipple. And if this is due to Paget's, what it reflects is DCIS, or ductal carcinoma in situ, involving the ducts actually opening onto the nipple. So we're looking at DCIS tissues coming out onto the nipple. Mammographically, we might see some calcifications in the deeper tissues, but a histologic diagnosis is needed to confirm this, and the pathologist will see what they call pagetoid cells in the nipple on a shave biopsy. Here's an image of what it might look like, a little bit of reddened surface of the nipple right there, Paget's of the nipple. Here's a patient that presented with itching of her nipple, and she was diagnosed as having Paget's of the nipple, and we see underlying on her mammogram a lot of pleomorphic calcifications in a regional distribution. Some are linear in branching, like this very nice pattern here of linear branching, but irregular calcifications. They're not smooth, they're not rod-like or cigar-shaped like secretory disease. They are irregular, they're classic high-grade ductal carcinoma in situ, causing Paget's of the nipple. Here's a different patient, a 72-year-old who had Paget's of the nipple. Here's her mammogram. Are there any lesions here? Hard to say. We don't see anything distinctly, but her breast is dense. So MRI can be very helpful here because it shows a single enhancing mass deeper in the breast. And this was actually an invasive ductal carcinoma. The more lower grade DCIS between that and the nipple doesn't really enhance. So that's it for itching. That was pretty short. Next is discoloration. Discoloration or redness can be due to several causes. It can be a skin disease, fungal, or other kind of dermatitis. Radiation therapy can leave something that looks like a sunburn initially, and then over time it will darken as the skin is a little bit thicker. And then usually it fades within a few years, but it may remain chronic. These discolorations aren't visible on imaging. If they're associated with thickness, we'll see that, but the discoloration we don't usually see. Okay, so next is ulcers or cavities, and these usually reflect either late-stage abscesses, serious abscesses, or late-stage cancers. Here's a patient that presented with a cavitation of her skin. This is the inframammary fold here. So this is her epigastric tissue, and then this is the inferior aspect of her breast. And you see right in the crease here, she has this cavity. Women often get infections in the inframammary fold where there is a crease because of moisture and difficulty keeping it clean. So it was thought that this was infection, treated for a number of months, but it didn't get better, just kept getting worse. Finally, a biopsy was done, and it was a necrotic cancer, cavitary cancer. Oh, just an example of a very advanced cancer on MRI that presented with breakdown of the skin. You can see this very large mass causing skin breakdown and enhancement right here. Okay, the last of the skin problems that we're going to discuss are thickening of the skin and peau d'orange. The peau d'orange, or skin of an orange, is described as the skin of an orange because that's what it looks like. The skin pores become prominent because the tissue around it becomes edematous. So there's swelling in between the pores. Differential diagnosis here is inflammatory cancer, lymphatic congestion, or benign edema. So if skin thickening is caused by inflammatory cancer, this is a clinical diagnosis, and it's a clinical presentation of carcinoma. It's not a different kind of carcinoma. It's due to invasive ductal carcinoma, but presents with inflammation because there is rapid access to the lymphatics of the skin. So because of that, these patients will present as though they have mastitis. The breast can be swollen, there's warmth because of the increased blood flow, and the skin is reddened. So initially, you might think the patient has mastitis, and if given antibiotics, they will sometimes improve a little bit. So we need to be careful about this and do a punch biopsy. Mammographically, what we're going to see is diffusely increased density because of all this swelling and skin thickening. You might see an underlying primary mass or regional pleomorphic calcifications, or you might see nothing other than the diffuse increased density. Usually there will be abnormal axillary lymph nodes by the time the patient presents like this. So this patient presented with red skin thickening. You can see mammographically the right breast is diffusely more dense than the left. There's skin thickening predominantly in the areola, a little bit in the skin here, extending beyond the areola. We do see what looks like a small mass here, and then just asymmetric density compared with the left breast. Sonographically, we see the marked skin thickening. We see the edema as reflected by the hyperechoic texture here, but we don't really see a discrete mass at that point. So that was cancer causing skin thickening, inflammatory cancer. This is lymphatic congestion causing skin thickening. This patient does not have a breast cancer, but she has an axillary mass here with a lot of lymphatic congestion, which causes thickening of all the lymphatic channels, and it collects more in the subareolar region. So adenopathy can cause lymphatic congestion like this. Benign edema can cause skin thickening as well. Congestive heart failure frequently will cause swelling in the breasts, like in this patient. In this particular patient, it's bilateral, but it can be unilateral in patients who remain largely on one side, like patients who've had a stroke or other kind of injury, and one breast is always dependent compared to the other, which will allow the fluid to accumulate in that breast. But generally, patients with CHF has symmetric edema, like in this patient. Okay, so that's the end of that module, and we will get on with the next one shortly.